So good morning. We are inviting Dr. Mohammad Saman, who is professor in biomedical engineering in the Boston University. First of all, thank you very much, Mohammed, for accept this invitation. And we want to start with a short introduction of yourself and your job.
Yeah, thank you so much, Oscar. It's wonderful to connect again after a few years, and I'm really excited about this project that you have ongoing with colleagues at EUI School of Translational Governance, Florence, and the University of Los Angeles in Bogota. As you said, my name is Mohammad Saman. I am a professor of biomedical engineering and also global health. I also direct a center, a new university-wide center on forced displacement, which works on addressing the challenges faced by refugees and migrants and stateless communities. So my own work focuses quite a bit on antimicrobial resistance and also access to healthcare among refugees and stateless communities, as well as internally displaced persons.
Excellent. So talking precisely about antimicrobial resistance, the first question is, what type of information is necessary to collect to understand the problem of antimicrobial resistance among migrants and refugees?
So I think this is a really good question. I would say there are several different types of information that is necessary. And the reason I say that is that if you think about antimicrobial resistance as a single problem, I think we will miss a lot of the information. So what we need is information which is basically, of course, clinical information and data that comes from that. So that's one part of things that we have to know. Two is general challenges associated with perception. So what do refugees and migrants think of antimicrobial resistance that affects their behavior and things like that? We also need to know, for example, what kind of drugs are available in the system, because in many places, there is no antimicrobial susceptibility testing. So people get not what they need, but what is available, right? So you may need amoxicillin, but if there's no amoxicillin in the system, whatever antibiotic is available in the system is given to you. So we need to have that information as well. And of course, trying to understand this in the context of mortality and morbidity would also be important. Too often, we do not have any good data on the mortality and morbidity of refugees and migrants. So I would say these are the 4 or 5 different areas. Of course, information about clinical isolates, but of course also the information associated with what kind of antibiotics are available in the system. It would also be valuable to understand perhaps some kind of environmental surveillance, and as well as information associated with behaviors as well. Now, the challenge with that is, of course, this all is perhaps too theoretical and too ambitious. So what ends up happening is that we end up collecting a little bit here, a little bit there, and then trying to piece together things. So I think that creates a lot of problems because we don't fully understand and appreciate the challenges that exist among these migrants and refugees. So one challenge is, of course, that there are high risks to their health, right? Because of poverty, underlying nutrition, disease exposure, but also because they may be living in places which have high levels of antimicrobial resistant pathogens. So that's one problem. The second problem is they also don't have access to healthcare if they get sick. So the kinds of drugs that they get is whatever is available in the market, or sometimes informal markets, sometimes counterfeit. So that's the second part of the problem.
Right.
The third part of the problem is that there's often no information on how to deal with antibiotics. So people treat their symptoms, not their infection. So they start to feel better after 2 days, they stop taking it and save it. So you have to really understand all of these things if you want to address the problem. You cannot look at only clinical isolates and not understand the fact that they have a high exposure because of wastewater, or the fact is that because of poverty, that the drugs that they may get may be fake. So you have to understand all of these pieces of information if you want to understand the issue of antimicrobial resistance.
Excellent. And what is the main source of this information on antimicrobial resistance among migrants and refugees?
So I think the information sources are very few and not very good. So what you end up finding are things that are coming from NGOs like MSF. So MSF, for example, has a clinic, and they may be doing some isolates. And if they choose to share that data with researchers or do research on their own, then you will find it. So the systematic work on this is very little. So WHO has an office on migrants and refugees. They looks at antimicrobial resistance, but it looks fairly at a high level, not necessarily at individual communities and looking at their challenges. So the challenges, let's say, of Venezuelan migrants in Cucuta or in northern Colombia are very different than the migrants that may be coming from within Colombia, moving from rural to urban areas as a consequence of the long sort of civil war, right? There are different kinds of things, and we too often try to bend them as one, which is not going to give you good information, right? So that's one thing. Two, you also need to divide it by socioeconomics or access. So there are people who may be able to go to Cucuta and come down to Bogota. There are people who are stuck in various places. There are people who are going back and forth. That information is often lacking. So that information is coming largely from different individual pockets who may choose to share or may not choose to share. And that creates a problem. So MSF may be able to analyze some data, or they may not be doing some of that. So I think the sources of information are what I would call ad hoc, as opposed to very reliable ones that are there. And there are no sort of large-scale studies that have been done. The other thing that I would say is important is also, remember, Oscar, we are looking at communities that are moving, but too often we collect the data of communities once they've reached somewhere. So if somebody's going, let's say, from Afghanistan or Syria to Germany or to European Union, the data that is collected is once they've reached the European Union, not the data on the journey. In fact, that continues to be a major handicap because we don't have any information about the antimicrobial resistance of the communities that are migrating. And too often we don't have any information on that. So that's, I would say, a gap in our understanding as well.
Excellent. And what is the type of analysis that you do with these data?
I think there are 2 or 3 different things that you would like to get out of that. One is looking at the trends. Are there some specific multi-drug resistant pathogens that we need to be aware of? And what are the drugs that are no longer working? So one is sort of the trends that in 5 years ago, this is what was happening. Now it is this. For example, there may be a typhoid outbreak, and you may see that increasingly the typhoid is MDR, multi-drug resistant, or XDR, extensively drug resistant. So one of them is looking at that kind of analysis. The second data is also dividing it up based on region or in socioeconomics or in age, or whether people are sort of, for example, migrating or are they settled. So that is the other kind of geographic, demographic data. I think the third thing, which is often lacking, is trying to understand whether the refugees are seeing something different from the local population. So, for example, let's say you want to do an analysis on in Cucuta, are the people who are coming from Venezuela seeing different levels of antimicrobial resistance than the local Colombian population of Cucuta, right? And that's important because then that gives you a sense whether there's something that is different about them, or are they seeing things that are already in the local region, so that you can come up with that. Eventually, what you want to be able to do is to be able to identify what I would say concerning patterns early on, so that you can have susceptibility testing early on and a better strategy. But too often that doesn't happen.
Correct. And what about the laboratories? What kind of information you can extract? And what about the genotypes? How that can help in this process?
Yeah, so I think that is going to be phenomenal, but unfortunately, there's very little information on that. So some of our work in Yemen has shown that the laboratory studies are very few. Most of the time, in many places, that means an out-of-pocket expense for people. So people try not to do it because it is expensive. And the state or the support for that is lacking. So that means that your ability to do these things is limited. So in the absence of genotyping or laboratory information, as I said, what ends up happening is people get the antibiotic that is available, not the antibiotic that they need, right? both in inpatient and in outpatient. So inpatient in many hospitals would get some kind of testing, outpatient very rarely, because the tests are expensive. The tests are also going to tell people what they don't want to hear. So the test will say, well, you need an antibiotic that is not available there, or you need an antibiotic that is very expensive, or you need 3 antibiotics that are very expensive. So that, I think, is something we have to know and subsidize that, because otherwise there is a disincentive for that. On the other hand, the data from the research standpoint is phenomenal. That, I think, is really important to understand both the local trends and also trying to understand the bigger picture of what might be happening. But one of the things, Oscar, I think that is often lacking is the data that we get is a single point in time. So March or April of 2023, we have no way of knowing what happened 3 months ago, 6 months ago, a year ago. And that is important, because if you want to see trends, or if you want to be able to come up with better policy, then data that is built over time is very, very important, right? We cannot have data that doesn't tell us that information, because in the absence of that information, we don't know whether what we are seeing is a phenomena that is real, or what we are seeing is something that is part of a disturbing trend.
Good. And if we talk not only about migrants or refugees, but in general, what kind of coordination exists between countries to share information about antimicrobial resistance?
Well, so I think that's a really good point. I think what we need is really several layers of coordination and data sharing. So we need things at the local level. What I mean by smaller towns and better surveillance systems. We need things at the municipal or sort of city level, and then onwards. In some ways, we have done, not perfectly, but at least have developed some strategies, let's say in the context of COVID, where there was information that went from small towns to mid towns to large towns to national databases as well. I think some kind of a similar surveillance would be good for antimicrobial resistance, but the difference is, and you know this very well, Oscar, antimicrobial resistance is not a single disease, right? It is not one disease that we are looking at. We are looking at different kinds of patterns here. We are looking at the presence of pathogens. We are looking at sort of changes in people's response to different drugs. We are looking for perhaps environmental sampling. So it's really multiple things. So we need different kinds of data coordination in that regard that doesn't exist right now, or at least doesn't exist in the way it should in terms of data analysis. Also, we need regional bodies. So when you're looking at, for example, looking at global trends, we are often looking at either high-income countries or countries with a large population base, India, China, Brazil. But we are not looking, for example, in rural communities in many parts of the world. We are also not looking oftentimes in smaller countries in Africa. And so I think there is a need for a much stronger coordination that starts at the local level and then builds on that.
And talking about the providers, including pharmacists and doctors, I know you do some survey on what they think about antimicrobial resistance. Could you tell us a little bit about that?
So we've done some work with providers, with doctors and nurses and pharmacists. They tell several things. One, they say that people demand certain kinds of antibiotics, right? So there's a demand side that I want an antibiotic because I think I have an infection. So there's that demand side. And in many places in the world, including the country where I'm from, in Pakistan, there is no strong prescription drug laws, which means people can go to a pharmacy and get any antibiotic, and the pharmacist will be happy to sell it to them. So pharmacists have a very important role to play in society in that, but people demand those, and they're demanding increasingly more and more what I would say high value antibiotics, high sort of value antibiotics that maybe should be only reserved for extreme uses. So that's one thing. Same thing with doctors. Doctors often would hear that their people want their children or themselves to get antibiotics, But also increasingly, both pharmacists and doctors hear that our antibiotics are no longer working. My drug doesn't work. My condition doesn't get better. So we're hearing sort of this anecdotally, even when people don't know what the term antibiotic resistance means, right? So people would come back and say, I've been taking it for 3 days. My fever hasn't gone down. My infection hasn't gotten better. My urinary tract infection or whatever it may be hasn't gotten better. So that's so give me something else or give me something stronger. That's what they would say. So that's one thing. The other thing you also know, but I also say that it's not that the doctors are not responsible. In many parts of the world, the doctors would prescribe antibiotics without any tests. They would say, you should get amoxicillin or ampicillin, or you should get on Cipro without doing any tests. They would do it on the phone. They would do it by looking at the patient. So the doctors themselves are contributing to this challenge in addition to the demand side. So because tests are expensive, because tests take time, because tests are not available everywhere, what ends up happening in that case is that people are able to have that transaction and continue to use antibiotics and also use them for a very short period of time and use the wrong antibiotics. So that creates a bigger problem. But I also think that in some cases, there's also the market equation. You have 3 or 4 doctors, one of them is unwilling to go and provide antibiotics. The patient ends up going to a different doctor who's willing to do that, right? So there's that competition in the marketplace also going on because there's no checks and balances in that regard.
Correct. And part of the training we are doing, we include the concept of One Health. So in related to antimicrobial resistance, especially antibiotic resistance, the use on animals is an important issue. Could you talk a little bit about that?
Yeah, as a matter of fact, Oscar, I think that remains a really probably a huge challenge that is both underfunded and underappreciated. So the animal challenges are severalfold. One, the regulation that is used in human sector is not used in the animal sector.
Yeah.
Large countries, including United States, do not necessarily follow the best practices and would find sort of loopholes to give antibiotics as growth promoters, as hormones, and they may not call it growth promoters, they may call it prophylactic, but it does the same thing. So there's that problem. And that's true all over the world, large countries and small. Then the other issue is that in the animal sector, you also do not have the same kinds of regulations in drug quality. So you may have bad quality antibiotics available in the system that are increasing development of resistance. Third, you also do not have enough veterinarians to look at that. So again, going back to the case in Pakistan, some of the large sort of buffalo colonies or milk producing colonies would not have any veterinarian. So you don't even know what kind of disease this animal would have. As a result of that, people will continue to give antibiotics or come up with their own ideas on mixing antibiotics together. And then the fourth one, of course, is the fact that we do not have enough research in understanding this link between human environment and animals very well. So we think we know at the higher level, at the super level, but individual mechanisms are still, in many cases, need to be elucidated. So the research side of that is also missing. Part of it is also because people like me and many others who work on this issue do not get enough funding to focus on the animal side as well. And that funding part to understand some of the mechanisms also is lacking. So as a result of this becomes a huge issue. And the One Health model will only work if all pillars, human, animal, environmental, all of them are able to work together. You cannot have a One Health model when only the human side is all where the research is and all the regulation is and all the awareness is, and the animal side is less, and the environmental side is even smaller.
Excellent. Okay, that was my questions. I don't know if you have a final comment, Mohammed?
I think the opportunity to focus on antimicrobial resistance on migrants and refugees and do so ethically is critical. I think it's very important. I think we are not doing enough of that. And I think to engage with local communities, local groups, local NGOs, I think this is an underappreciated issue and one that I am very passionate about. I would love to hear from the people who you work with, who you interact with, and we would love to work with them because I think this is a really important issue and one that does not get enough attention.
Okay, thank you very much, Mohammed. We will continue to work together and very happy with your experience and what you share with us. Thank you very
Looking
much.
forward. Take care.